Hello everyone. Today it's a huge pleasure to have Dr. Bharathi Balachander here with us. Dr. Bharathi is a professor in neonatology at St. John's Medical College in Bengaluru. Her interests are in infection prevention, neonatal urology, and QI. Dr. Bharti has extensive experience and has many awards in this field of neonatology, including the best outstanding outgoing medical student in her MD and her DM together, and also a best thesis award. So we're really very lucky to have Dr. Bharti with us today and talking about PWS. So Dr. Bharti, over to you and thank you.
So at the outset, I thank ORDI and the team for this gracious invitation, and it's a privilege and honor for me to be here. And thank you, Dr. Shweta, for the kind introduction. I'll just start sharing my screen. Yeah, so is my screen visible?
Yes.
So we all know that today we are going to look at one of the rare diseases, that is Prader-Willi syndrome. And what I'm going to present here is a journey of a baby from the neonate to infancy and toddlerhood. This is one of the rare syndromes, but then uh, early diagnosis and early intervention has the power to change the course of these infants. So let us see how. So the outline of my talk is to understand what is Prader-Willi syndrome first, to understand their journey over time, and also with illustrative examples. So especially for the neonatologist, what the mind does not know, the eyes do not see, and we perceive that it does not exist. So knowledge is the first thing for us to have an early diagnosis, and early intervention can change the course of the lives of these babies. Before I start off, the history of Prader-Willi syndrome is quite interesting. It was first described by a trio. The same trio now are managing these babies, a trio of pediatrics, endocrinologist, and the head of neonatology, Dr. Prader, Dr. Labat, and Dr. Willi. They saw a constellation of babies who were eating too much, which was the view. They also had deficient control of their emotions, exuberance, and stubbornness. This was all described in the 1950s, and by the 1980s, it was known that they have a characteristic gene problem in the chromosome 15q11 to q13. So this was initially named as Prader-Labat-Willi syndrome, and over time, unfortunately, the name Labat was actually dropped down. But today, we understand that endocrinologists play the most important role in the journey of a baby with a Prader-Willi, and we will see how. So to define syndrome, it's a complex, rare genetic disorders that affects multi-body systems. It is also one of the most common cause of life-threatening childhood obesity. The incidence is actually 1 in 15,000. So that is the least incidence which I got. There are reports of 1 in 20,000, 1 in 30,000. This is an approximate prevalence. It's a complex multi-system disorders, and there are a range of symptoms ranging from the neonatal period to adulthood. So let us see them one by one. So the first thing, to go over through the genetic etiology. So which is the gene which causes all this trouble? It is in the chromosome 15. So Prader-Willi syndrome is caused by the loss of function of specific gene in the 15q11 to q13 of the paternal chromosome. And this is an imprinted region, which means that the genes are expressed only from the father's copy. So there are three main mechanisms. So this is outlined in the figure on the right side of the screen. So there are three main mechanisms. The first thing is called paternal deletion. This accounts for 65 to 75% of Prader-Willi syndrome, which means, so you can see that there is one chromosome which is inherited from the father, marked by P, one chromosome inherited by the mother, marked by M, and there is a missing piece in the paternal chromosome. So this accounts for most common causes of Prader-Willi syndrome. The next cause, genetic cause, is what is called as uniparental disomy, which accounts for 20 to 30%, which means both the copies of the chromosome are inherited from the maternal side, and there are no paternal genes which are inherited. The last is called as imprinting defect. The chromosome is, there is one chromosome from the paternal side, there is one chromosome from the maternal side. But the critical regions which account for the Prader villi are silenced. So when we go in depth into Prader villi, you can look and see that this is the chromosome 15. There is a non-imprinted region. There is a PWS region. There is an AS region, which is called as Angelman syndrome. And there is a non-imprinted region. Based on the type of deletions, there are subtypes of Prader villi. So in the paternal deletion, we can see there are breakpoints. This is BP1, BP2, BP3, BP4, and BP5. If there is 1A, that means there is deletions from breakpoint 1 till breakpoint 3. 1B is from 2 to 3, and 1C is from 1 to 4, and 1D is from 1 to 5. The uniparental disomy is again classified into either it is isodisomy or heterodisomy, and imprinting defects can be center deletions or epimutations. However, based on the genotypes, there is not much difference in the phenotypes for deletions and uniparental disomy, except that imprinting defects may not have the full-blown characteristics of Prader villi. They may just present as babies who have autism later on. So keeping in mind the genetics, let us now go into the clinical features of these babies. So the first stage is infancy. Now, everyone thinks infancy starts with the neonate. That's not true. We have another patient who is also the fetus. So it starts prenatally. So what happens to the fetus is that the fetus could have difficulty in swallowing, leading to polyhydramnios and intrauterine growth restrictions. Depending upon the genotypes, these babies may be born either preterm or they may be born postterm. This will be better explained in the illustrative examples. The hallmark of a baby with Prader Willi in the neonatal period, which every neonatologist needs to know and recognize, is that they are floppy babies. The hallmark is severe hypotonia, that is low muscle tone. We can see as elicited in the diagram over here that when we are doing a pull to sit examination, there is a severe head lag. And when we are doing a 180-degree flip test, we can see that these babies do not have a power to flex the tone to flex their legs. They have weak suck reflex. So one of the things the baby may present to either in the hospital or to the OPD basis that there is poor feeding, and often these babies require specialized orogastric or nasogastric feeding for months on end. They have failure to thrive in the initial phases of the neonatal period and infancy. In fact, their weight gain will be so slow because of their poor feeding. And they can have delayed milestones, especially the motor milestones. There will be significant delay in lifting the head, sitting up, and crawling. In the initial period, that is during the first infancy period, they are often labeled as very good or quiet babies. They do not cry much and they are extremely silent. Another hallmark which we see during this pulse oximetry monitoring era is that these babies have a lot of desaturation and they tend to have oxygen dependency because of their hypotonia. These features all put together should make the neonatologist have a suspicion of Prader-Willi syndrome. Moving on to stage 2, where it becomes the exact opposite. This is starting at 2 years of age. These babies turn over to the other side. The clinical picture evolves dramatically. They start having hyperphagia, that is an unrelenting, insatiable hunger driven by hypothalamic dysfunction. Without strict environmental control, this leads to rapid life-threatening central obesity. And the paradoxical thing is that their metabolic rate is lower than average due to their decreased muscle mass. So to outline the clinical features, I would not go into much into adulthood. In the prenatal period, as described, they would have low fetal movements, decreased swallowing, polyhydramnios, and lower weight. In the first 9 months of life, hypotonia, feeding difficulties, low appetite. In the second year, starting after the first year, their feeding starts to improve, their appetite starts to improve, their weight starts to catch up. In the 2 to 8 years, they start having increase in weight without much increase in the appetite or excess calories. By 8 years, we get the full-blown picture. They become hyperphagic. Rarely their appetite is satiable. We need to know what are the distinct phenotypes. So one is the facial dysmorphisms. As we can see, they have a dolichocephalic head with a very narrow almond-shaped eyes, narrow temple distance, with mild strabismus, thin upper lip, and downward turned mouth. During the neonatal period, they tend to be low birth weight or IUGR, and over time, they start to become overweight. Another hallmark in male babies is that they would have cryptorchidism or undescended testis. The other hallmarks are acromeria, micria, that is small hands and feet. These are again a diagnostic clue. Over time, they have short stature, which is attributed to growth hormone deficiency. Now, especially for neonatologists, where the diagnosis in the neonatal period could be confusing with, especially where India is the IUGR capital of the world. This is one of the diagnostic criteria which is akin to the Hall's criteria for Down syndrome, which could be used when we are suspecting a Prader-Willi. This consists of major criteria, minor criteria, and supportive points. So to score, we'll have to give 1 point each for every major criteria, half point each for every minor criteria. Supportive findings are not scored. So if we have 5 points for a baby less than 3 years and 8 points, of which at least 5 are major, for babies more than 3 years, there is a high diagnostic suspicion of Prader-Willis. Interestingly, these clinical scoring systems were very much used during the time where genetic tests were not easily or readily available. So the other hallmark is the cognitive and behavioral profile. So one thing is they have mild to moderate intellectual disability, but their plus point is their strengths are in visual organization. They may be very good at solving puzzles. They have a lot of behavior issues in the form of temper tantrums, stubbornness, rigidities, also tend to have compulsive behaviors like skin picking. There can be excessive daytime sleepiness and also nighttime lot of awakening due to sleep apnea and due to hypotonia and obesity. The main issues in, The main issues in Prader-Willi syndrome are the endocrine issues. And one of the mainstay is the growth hormone deficiency, which leads to most of the features. So can we look at the picture A and B above and C and D below? Now, what we can say is this picture speaks 1,000 words. This is a 7-year-old child. A and C are a 7-year-old child. A is a baby or child who is not treated with growth hormone, whereas C is a baby who is treated with growth hormone. Similarly, B is a child who is not treated. Of course, they're not the same children, but at the same age, 13 years of age, not treated with growth hormone. D is a child treated with growth hormone. Growth hormone makes a lot of difference to these babies, and they are the mainstay of treatment in Prader-Willi syndrome. They can also have thyroid dysfunction because of obesity, can have diabetes, can have adrenal insufficiency, and hypogonadism. The other issues include strabismus, hip dysplasia, and scoliosis, which also requires them for periodic ophthalmic and orthopedic evaluations. Now coming to the management of Prader-Willi syndrome. So it is not an individualized treatment alone. It requires multidisciplinary therapy in the form of neonatology, pediatrics, starting with the diagnosis. An endocrinologist is the heart of the management, nutritionist, neurodevelopment and behavioral pediatrics, pulmonary medicine, speech and language, and geneticists. And what are the hallmarks of, what are the mainstays of management? It includes their complex medical needs, education, coordination, and finances. So you can see a hall filled with people on the right side. So these are all the departments which actually came together at St. John's in February 2025 to have a treatment planning of babies who were diagnosed with Prader-Willi syndrome, 3 of whom are on our follow-up. I'll start again classifying with the neonatal period. For the neonate, the first thing is early recognition. And for early recognition, we need to have a high index of suspicion. Once a diagnosis is established, we need to have supportive care of the floppy or the preterm baby. Their main problems would be feeding issues and extrauterine growth restriction. That is, they would be IUGR, but then later also their weight gain would be a problem. So for genetic diagnosis, how do we get to the diagnosis? The main investigation which we need to send is methylation studies using a multi-ligand pro-assay. So this is one of the reports of our babies who had diagnosed pathogenic Prader-Willi. We can see that there is what is called 100% methylation. What does it mean? All the methylated genes are inherited from the mother's side. All the non-methylated genes are inherited from the father's side, which means that there are no paternal genes here which are deleted. It shows a heterozygous and also 100% methylation. So it means that this has no paternal genes of the chromosome 15 in the region of Q11 to Q13, which indicates Prader-Willi syndrome. So once we have hypermethylation, Prader-Willi, we find whether there is an abnormal copy, then it leads to paternal deletion. If there's a normal copy, it could be a uniparental disomy or an epimutation. So we can confirm with using a fish. If the fish is abnormal, that means there could be a translocation. If it is normal, it could be an epimutation, which needs a single nucleotide polymorph or linkage analysis to identify. If the MLPA is normal, then we would do a DNA sequencing. If it is normal, we need to look for other tests and other diseases. If it is abnormal, we look for PWS key gene mutations. The other alternate option is a chromosomal microarray. But the first line test of choice is the methylation studies using the MLPA. So these are all the molecular tests which are available, and amongst them, the most common test which we have to remember if we are suspecting is to send a DNA methylation studies to identify deletions, uniparental disomy, or the imprinting disorders. Now moving on to infancy, that is the period of 0 to 1 years. The main thing these babies need is support for feeding, developmental support, that is early intervention. Management of cryptorchidism needs to be addressed by 1 year, and preparation for growth hormone replacement. Again, these babies need vision assessment for strabismus. So I said the mainstay of treatment is growth hormone. How do we start this growth hormone and when to start? There is actually speaking, there is no age limit to start this growth hormone. But the limiting factor to start growth hormone is that we need to obtain what is called as a polysomnography. Why? Because these babies have obstructive sleep apnea, and that can lead to, that can worsen once growth hormone is started. The limiting factor is pediatric pulmonologists, and interpretation of polysomnography is quite difficult in babies less than 2 years. So if there is no sleep apnea present, we can start growth hormone straight away. It is started at a dose of 0.5 to 1 milligram per meter square per day. Otherwise, it will require treatment of the sleep apnea, sleep disturbance, and then after that, we would have to start the growth hormone. Once the growth hormone is started, still we need to look at IGF levels. We need to repeat the polysomnography studies and monitor these babies, continue this treatment into adulthood. So even though growth hormone is the mainstay of treatment, it's not an easy treatment. It still needs a lot of close monitoring. So this is the starting dose, 0.5 milligram per meter square, can increase up to 1 milligram per meter square over a period of 3 to 6 months. It is better to use body surface area to avoid very inappropriately high doses in overweight or obese individuals. The babies of, the Prader-Willi syndrome babies are quite sensitive to this GH therapy. We need to check the IGF levels after 1 to 2 months and also monitor these babies for the complications like hypertension, acromegaly, poor glycemic control, increased risk of obstructive sleep apnea. So pulmonology, that is another heart of Prader-Willi syndrome management. Why do we need the pulmonologists? Because these babies have a high incidence or prevalence of obstructive sleep apnea, and they need polysomnography studies, which are crucial or crux of accurate diagnosis and treatment of this condition. And these are very important to be done before initiation of growth hormone therapy. Inappropriate diagnosis or management of OSA can lead to sudden deaths even if growth hormone therapy is started appropriately. So this is quite important. So as you can see, this chart gives us the list of things these babies need to undergo from the newborn period, from 1 month to 1 year, 1 to 5 years, and 5 to 13 years. So all these babies require periodic medical evaluation in the form of feeding, growth, development, tone assessments. By 1 year onwards, they would also start to have sleep problems, behavior problems, nutrition issues, which need to be focused upon. All these babies should be given anticipatory guidelines, medical referrals, especially to genetics, endocrine, ophthalmology, pulmonology, nutrition at every visit. And these are the labs which need to be periodically repeated. And these are the treatments. So the main treatment in the infancy is one, to start growth hormone if feasible. The second, if there is cryptorchidism, we need to start HCG or testosterone and plan for surgery for this cryptorchidism. So the main thing why Prader-Willis should be diagnosed early and intervention should be provided is that if we identify them early, they will not go into this obesity and hyperphagia. So prevention of obesity is the most important, and they need to have a very, very structured lifestyle to prevent this at 8 years. So what are the key things we need to advise them? One is dietary strategies. They need to have very secure homes and balanced plate in the form of strict food control, balanced low-calorie diets, smaller plates, bowls, nutrient-dense food, limit sugary foods, never use food as reward. Lot of physical activity to move their body, live their best. Daily exercises which are varied, supervised, individualized. Structured programs can be best given by the physiotherapist. Also behavioral management. So they do well when they have consistent routines, positive reinforcement, and teamwork. Everyone should be on board. And it is very important, especially as healthcare providers, that these babies or parents should not be shamed or should not be treated differently for their physical appearance. So I talked about all these care which has to be done. This is a paper which is done in France where early diagnosis and care is achieved but still needs improvement. So France is a high income country with all the resources. So this paper in 2017 talks about how these babies were diagnosed and managed. So the number of infants they had over a period of 1 year were 38. Their median age of diagnosis was 18. So they had no antenatal diagnosis despite 3 or 4 babies getting a fish or karyotype for IUGR. Some 3 of these 38 babies had a delayed diagnosis which was only at 3 months. 84% of these babies required nasogastric feeding. 94% of these babies were hospitalized. 45% of these babies only got feeding assessment, that is swallow assessment, in the newborn period. Only 76% of these babies got physiotherapy in hospital. But 80% of these babies were seen by an endocrinologist within the first month of life. Yes, so at every place, this paper actually talks about the scope for improvement, which is same for our country as well. Let us now go to the next section. So I'll be talking about some examples which of babies who were diagnosed in our center. So the first baby, who is presently 2 years, 3 months old, was born at 34 weeks, 1.6 kg, was born out of a non-consanguineous marriage to a G3P2L1D1 mother. So the mother had lost her first baby due to abruption. And again, she presented with abruption and a preterm delivery. All the antenatal scans were normal. There was no FGR, no polyhydramnios. So this baby, on presentation, baby got intubated because the baby was quite floppy. So when we saw, the baby was actually alert, could respond to touch, had some occasional spontaneous eye movements. But then the tone was very poor. There was generalized axial and appendicular hypotonia. Despite the tone being poor, the baby had good power, that is grade 3. So this is what we call as a floppy strong baby. The DTRs were preserved and all the cranial nerves were normal except the fundus was pale. So we put this baby into the bracket of floppy strong, and when we looked at the algorithm, we could see that one of the hallmarks of floppy strong diagnosis would be either trisomy 21, Prader-Willi, or Zellweger syndrome. And amongst them, this baby did fit into Prader-Willi. Then, unfortunately, this was one of the first babies we did encounter. We did send for a exome sequencing for this baby and fish. And this baby was diagnosed after 3 weeks of hospital stay to have Prader-Willi syndrome with the deletion at the SNRP gene on Q11 to 13. So this baby had ventilation for 15 days, a prolonged oxygen requirement, quite a stormy course, a floppy infant, and he was discharged actually on home oxygen and tube feeds. So still he's not 2 years, but still his growth is lagging, not gone into the obesity phase. Has a very sweet temperament. In fact, this baby was readmitted for cough, cold, fever, and was one of the most popular babies in the pediatric ward, although there is a developmental delay. Has recurrent respiratory infection. So when you see the weight of this child, see from the neonatal period to the infancy, that is to the toddlerhood, this baby is starting to have the weight gain problems. The length is normal. The head circumference is also within the normal limits. So in this baby, in a preterm baby who is floppy but strong, again, we need to keep a suspicion of Prader-Willi syndrome. These babies may require a prolonged NICU stay and prolonged oxygen requirement. They need a lot of preparation during the NICU stay and for follow-up for their medical and other needs. The second example, so this was fairly straightforward. This baby came at 40 weeks, 3 kgs, was born outside, had a weak cry at birth, was born to a primary mother with normal antenatal scans. The only history which was there antenatally was reduced fetal movements in the last 2 weeks. All vitals were stable except that there was oxygen requirement. The hallmark again was retrognathia, synophrys, and bilateral cryptorchidism, and again a floppy strong baby. So this baby had problems of poor feeding, hypoglycemia, jaundice, again oxygen requirement, was discharged after 15 days. Again, this baby also was discharged on tube feeds, was on follow-up with us. By 2 months, this baby's tone started to improve, feeding started to improve. He is also 2 years. Presently, is running, walking, talking, mild developmental delay. Also had bilateral cryptorchidism. After a trial of HCG, he got operated at 1 year. Now you could see that this is a baby who is transitioning very rapidly into the obesity spectrum as indicated by the growth chart. His head circumference is normal. So again, in this baby, a high index of suspicion with the use of fish actually accelerated the diagnosis. There was an early management of cryptorchidism, but then presently, we need astute monitoring for obesity prevention. So this was a baby at 3 months of age, and this is a baby at 2 years of age. We can see the stark difference between the IUGR and the road on to obesity. The last illustrative example is a 37-weeker, 2.5 kg, who was late onset IUGR. So IUGR is again a hallmark. This baby was the third sibling, that is G5P2. There were 2 previous abortion and 2 living issues who were normal. This baby did not cry immediately after birth, was shifted to the NICU. And as soon as the baby is born, because we had the experience of the previous 2 babies, we were able to pick up hypotonia and Prader-Willi syndrome quite early in the neonatal period. And this baby had the earliest time to diagnosis, which is 14 days from the time of birth. And the diagnosis was done by the methylation tests, whereas the other 2, one was a fish and the other was a exome sequencing. So this baby is presently 1 year old. His weight gain is present. He's optimal. There is developmental delay. For cryptorchidism, he's getting a trial of HCG and preparation for surgery is ongoing. So this is a journey of this baby from 3 months to 9 months of age, where this baby is still on tube feeds and intermittently was on home oxygen and presently is doing well without any oxygen requirement. So lessons learned is that there's an improvement in gestalt diagnosis over time. The presence of a multidisciplinary committee quite helped this baby's follow-up to do much better, and especially a presence of a protocol, although it is not written, but then we had formed a sort of a protocol which we attached to the baby's case sheet. So Prader-Willi is becoming more and more common, and it is becoming an emerging problem with more early diagnosis. So this is a recent study published in China in 2016, where over a period of 1 year, there were 20 cases of Prader-Willi syndrome. And the most common problem, so you can see almost all these babies have similar type of faces and similar presentations. That is, they're all on feeding tubes. Feeding difficulty was the most common problem. 4 were premature, 1 required ventilation. Many, almost half of them had normal EEGs, half of them had abnormal EEGs, and the length of the hospital stay were between 10 days to 38 days. So to summarize, Prader-Willi syndrome is a rare but an important diagnosis to be considered in floppy babies. The most common presenting symptom is feeding difficulties. The journey can be characterized by a transition from IUGR to feeding difficulties to obesity and hyperphagia. DNA methylation is the diagnosis of choice, and growth hormone is the mainstay of treatment. Thank you.
Thank you, Dr. Bharti. That was a very informative talk. And just quickly, I think there's a question from the audience.
Okay.
In some Prader-Willi syndrome, growth hormone therapy is associated with sudden death. Can you
Yes.
comment on that?
Yes, so the growth hormone therapy, yeah, although it is a mainstay of treatment and it needs to be given, what happens is we need to evaluate these babies for obstructive sleep apnea through a polysomnography. So if we do not treat the obstructive sleep apnea and start the growth hormone, these babies are at risk of sudden deaths. Otherwise, if they are treated well and then we start the growth hormone, they need ongoing monitoring, which we should not compromise even after starting growth hormone therapy.
I think that was. Maybe I had a question. When
Yeah.
you sort of mentioned at this age, this happens, for example, weight gain starts at around 2 years. What is the range, the standard deviation, in around which this happens? Is it a fairly broad spectrum in which the changes can happen for some people in 2 years, some people in 6, or is it, fairly rigid where it starts at around 2 for almost all children?
No, it is a broad spectrum. We have to start anticipating that these babies are going to transition from their IUGR status to the obesity starting from 9 months. So all our behavior or modifications should start as early as possible. So when we are going to counsel them, we have to start telling them, preparing them for the fact that obesity is going to be the problem. So start doing dietary management, start doing the early intervention, that is a physical therapy, and also behavior. So especially when there is a good family support, and also there are good routines established in the family, the trajectory of this obesity can be actually changed for an individual baby. So it is also there partly in our healthcare workers' hands how we can manage this obesity better in these children.
If anyone has any questions, please feel free to put it in the chat. But I actually had one more question.
Yeah,
You
yeah.
said that the Prader-Willi is becoming more common. Why is that? Why is the incidence increasing? Is it just better diagnosis, or is there
One
actually an
is
increase in?
one is better diagnostics. Probably that is the case, but they're
Mm,
also known. Imprinting disorders are known. I mean, the literature is quite variable on this. Are known to increase with IVF. One of the causes in vitro fertilizations.
mm,
So, which is why the earlier reports, whatever I had read, were all 1 in 20,000 to 1 in 30,000. The recent reports are all 1 in 15,000. So we
mm,
will have to see. So which means that even in our own institute, we had not been seeing Prader-Willi so often before. And this last 2 years, we had almost 3 babies. Whether our gestalt improved or whether the diagnostics access improved, or is it that the incidence is increasing, we are not able to say.
And now with the these new drugs that are coming out for diabetes, etc., the GLP-1
Yes.
drugs, do you think with that management of Prader-Willi in especially in childhood and adulthood, will that be a lot easier? Will, for example, some of these children be able to live like more healthy lives because of these drugs?
Uh, Possibly, I do not know, but the main thing, I mean, so I was concentrating only on neonate and
Yeah.
the infancy. So the main thing I was harping on is prevention for
Yeah.
them going into obesity and diabetes.
Yeah.
So yes, possibly all these newer drugs definitely would have a role. And the most important thing which has a role actually in preventing these obesity, diabetes spectrum is also the growth hormone, which is
Hmm.
which needs to be optimally given and optimally managed.
I see. Okay.
So these two things would go hand in hand. Yes.
There's one more question, which is how many cases of PWS have you had? And out of this, how much has been associated with IVF?
We have had three, and none of them are associated with IVF pregnancy. All three are natural conception. Mm, so it's reported in literature. Again, the studies are divided. Some say there is no increase, some say there is an increase. So we will have to see what is it. And especially where premature babies are concerned, they naturally tend to be floppy. So unless we follow them up, maybe there is a missed opportunity for diagnosis. So we will have to wait and watch and see.
Since you mentioned growth hormone is the main, the main source of intervention, what are the ways in which you test if it's working appropriately, if the dosage is correct? Are there some, a list of metrics that you should look out for along with your endocrinologist?
So one is we will have to look at their own growth, the growth profiles. The
Mm,
other is what they say is use of IGF levels along
mm,
with the insulin-like growth factor levels and titrate the doses. So if you take body weight dose alone, they say that it can be very high for a baby with Prader-Willi syndrome. So we should optimize it to a body surface area dose. So these are the two things we need to monitor. Additionally, we have to monitor for the adverse effects, which are more than the effects itself.
mm.
So the adverse effects like them going into obstructive sleep apnea and things like that. So growth hormone comes with a lot of problems and also a lot of miracles. And we need to take these babies into the right path for their right diagnosis and management. Mm. Again, the other problem with growth hormone is it is also costly, which you
Mm,
must be knowing. So one injection is 4 units and it
mm,
costs almost 2,000 to 2,500,
mm,
which is 2,000 rupees per day. If you have to give it as a daily dose, which
mm,
almost comes to, you take 365 days a year, which almost comes to 3.5 to 4 lakhs for the medication alone. Then additional cost will come for the testing. So there are a lot of, even for our babies, there are a lot of hampering factors to even start the growth hormone itself. We have
Hmm.
we are still in the phase of exploring and redirecting them towards growth hormone therapy. So the median age in low in middle income countries to start is 2 years, because that is when we could get the sleep studies done, correct their OSA if they have any, and then start the growth hormone. And by these 2 years, the other problems which we did face is that these babies did have multiple admission for respiratory infection itself. Since they are floppy, that is the other problem which they have. So which took a long time for them to get out and settle down. So let's see.
Yeah. Are there any more questions? Maybe we'll just wait for maybe 30 more seconds in case
Sure,
somebody else
sure.
has any more
No
questions.
problem. So does ORDI have a registry of any Prader Willi? Or do we have a Prader Willi support group?
Yeah, we have, ma'am.
Okay. Maybe we should enroll our babies into them.
Yeah.
Yeah. Okay, looks like there's no more questions. Chetna, should we?
Yeah, ma'am. I think we are going to end the session.
Okay.
And thank you so much.
Thank you, Dr. Bharti, for doing. Yeah, it was very, very informative. I think all of us would have learned a lot.
Thank you, Dr. Shweta. Thank you, Chetana, for inviting me to this. I really actually, I mean, I had a thing to put opportunity to put everything together and present it to this forum. So thank you once again.
Thank you so much.
Thank you so much, ma'am.